Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. A virtual clinical pharmacy institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 278 of our pharmacotherapy series, which majors in essential hypertension. The first question reads, STJ is a 58-year-old man with a 10-year history of hypertension. He has been treated with lisinopril with hydrochlorothiazide 20/25 mg daily and amlodipine 10 mg daily for more than 2 years, and his BP has been well controlled during this time. His BP at an office visit today is 128 systolic 74 diastolic and 130 systolic 72 diastolic. He has no significant past medical history and has no hypertension-associated complications, but he is a smoker. STJ also has dyslipidemia, which is well controlled with simvastatin 40 mg daily. He denies dizziness or difficulties with his medications. Should STJ's antihypertensive therapy be changed to reduce his medication doses or possibly discontinue some of his medications? Some patients with hypertension can have their BP medications slowly withdrawn, resulting in normal BP values for weeks or months after discontinuation of their medications. This is called step-down therapy. However, it is not a feasible option for most patients with hypertension. Primary prevention patients with no additional major cardiovascular risk factors who have very well controlled BP for at least 1 year might be eligible for a trial of step-down therapy. This option should not be considered for patients with other major cardiovascular risk factors or hypertension-associated complications. Step-down therapy consists of attempting to gradually decrease the dosage, the number of antihypertensive drugs, or both without compromising BP control. Abrupt or large dosage reductions should be avoided because of the risk of rapid return of uncontrolled BP and even rebound surges in BP, as is seen with rapid withdrawal of a beta blocker or an alpha-2 agonist. Step-down therapy is most often plausible for patients who have lost significant amounts of weight or have drastically changed their lifestyle. Any attempt at step-down therapy must be accompanied by scheduled follow-up evaluations because BP values can rise over the course of months to years after drug discontinuation, especially if lifestyle modifications are not maintained. With adherence to lifestyle modifications, weight loss and reduction in sodium and alcohol, nearly 70% of patients remain free of antihypertensives for up to 1 year after being withdrawn from thiazide-based therapy in the hypertension control program. Step-down therapy in STJ is not an option. Although he does not have hypertension-associated complications, he has multiple major cardiovascular risk factors for development of cardiovascular disease. The next question reads, PAR is a 49-year-old black woman with type 2 diabetes mellitus. She started lisinopril 10 mg daily 2 weeks ago when her BP values were around 155 systolic 90 diastolic. Since then, she has had weekly BP measurements, and her values have averaged 145 systolic 85 diastolic despite strict adherence to her lifestyle modifications. Her BP today is 144 systolic 84 diastolic. It is 142 systolic 88 diastolic when repeated, and her heart rate is 78 beats per minute. She is not a smoker, and her BMI is 29 kg per meter squared. All her laboratory test results, including kidney function, are within normal limits, except that her spot urine albumin to creatinine ratio is 80 mg per gram. 2 weeks ago it was 90 mg per gram. Is 2 weeks of lisinopril therapy long enough to assess her antihypertensive response? Most ACE inhibitors are dosed once daily in hypertension. In general, most ACE inhibitors, if used in equivalent doses, are considered interchangeable. The time to reach steady-state BP conditions is similar to what is seen with other antihypertensive agents. It may take several weeks before the full antihypertensive effects of ACE inhibitors are seen. Therefore, evaluating BP response 2 to 4 weeks after starting or changing the dose of an ACE inhibitor is appropriate. PAR has been taking lisinopril for 2 weeks, and her present BP should be used to determine whether she has attained goal. Both her BP range during the past few weeks and today's average BP are above her goal of less than 140 systolic 90 diastolic. The next question reads, why should PAR have serum potassium and serum creatinine monitored while on lisinopril therapy? Serum potassium can increase with ACE inhibitor therapy as a result of aldosterone reduction. Potassium increases with ACE inhibitor monotherapy are small, typically 0.1 to 0.2 milliequivalent per liter, and usually do not cause hyperkalemia. This risk is increased when ACE inhibitors are used in patients with significant chronic kidney disease with a GFR less than 60 ml per minute per 1.73 meters squared, or when they are used in combination with other drugs that can also raise potassium. ACE inhibitor therapy can also cause a small increase in serum creatinine owing to decreased vasoconstriction of the efferent arteriole in the kidney. This results in a minor decrease in GFR that may be evidenced by a small increase in serum creatinine. A common mistake is to discontinue an ACE inhibitor in response to this rise in serum creatinine. Increases in serum creatinine of up to 30% from the baseline creatinine value are safe and anticipated. In these patients, the ACE inhibitor should be continued because a strong association exists between acute increases in serum creatinine of up to 30% that stabilize within the first 2 months of ACE inhibitor therapy and long-term preservation of renal function. Patients with an increase in serum creatinine of greater than 30% should have their ACE inhibitor therapy temporarily discontinued, as this may indicate other medical problems. Some of these problems can be underlying renal disease, such as bilateral renal artery stenosis, or other situations that may be compromising renal blood flow, e.g., volume depletion, concomitant nonsteroidal anti-inflammatory drug therapy, and heart failure. Serum potassium and serum creatinine, in addition to BP, should be monitored in PAR within 2 to 4 weeks after starting ACE inhibitor therapy or increasing the dose. The next question reads, PAR's lisinopril dose is increased to 20 mg daily. Will this doubling of her dose place her at risk for significant hypotension? The very elderly patients with volume depletion or patients with heart failure exacerbation may experience a significant first-dose response to an ACE inhibitor. This can manifest as orthostatic hypotension, dizziness, or syncope. The increased pretreatment activity of the renin-angiotensin-aldosterone system, coupled with blockade of this system, explains this effect. In these patients, ACE inhibitor therapy should be initiated at half the normal dose, followed by slow titration to standard doses. Concurrent diuretic therapy may predispose some patients to first-dose hypotension. When ACE inhibitors were first approved, dosing guidelines recommended starting at half the standard dose of the ACE inhibitor, decreasing the dose of the diuretic, or stopping the diuretic before initiating the ACE inhibitor. This was owing to fear that BP would sharply and acutely drop. These dosing recommendations are not necessary unless the patient is hemodynamically unstable, volume-depleted, hyponatremic, or poorly compensated heart failure, or very elderly. PAR does not have any of these characteristics and can safely increase her dose of lisinopril. The next question reads, is an ACE inhibitor an effective therapy in a black patient such as PAR? ACE inhibitor monotherapy is generally more effective at lowering BP in white patients than in black or elderly patients. In fact, JNC8 guideline does not recommend the use of ACE inhibitor or angiotensin II receptor blocker as first-choice antihypertensive in black patients for primary prevention, including those with diabetes, unless they have chronic kidney disease. Elderly and black patients are more likely to have low renin hypertension, which may partially explain some of the differences in response. Nevertheless, many of these patients still respond to ACE inhibitors as monotherapy, just to a less extent. Combination therapy, especially with a thiazide diuretic, usually mitigates this race and age-related difference in BP response. When an antihypertensive agent is being selected as initial monotherapy in a black patient, an ACE inhibitor should generally not be chosen unless the patient has chronic kidney disease. A thiazide diuretic or calcium channel blocker is otherwise preferred. In this case, considering switching to a different agent, thiazide and calcium channel blocker, may be a good alternative to improve PAR's BP control. Of note, black patients have a twofold to fourfold increased risk of angioedema and cough with ACE inhibitors compared with white patients. This does not preclude ACE inhibitor use in black patients unless there is a prior history of angioedema. The next question reads, PAR has microalbuminuria, and lisinopril may help preserve kidney function. However, is there a risk that lisinopril can cause acute renal dysfunction? The ACE inhibitors are effective in patients with hypertension-associated renal disease. They are contraindicated, however, in several situations, including bilateral renal artery stenosis, pregnancy, and volume depletion. In the case of bilateral renal artery stenosis or volume depletion, high angiotensin concentrations maintain renal blood flow, and acute renal dysfunction can occur when an ACE inhibitor is started. Because it is often not known whether a patient has bilateral renal artery stenosis, problems with ACE inhibitor can be minimized by starting with recommended doses and careful monitoring of serum creatinine within 2 to 4 weeks of starting therapy. Modest elevations in serum creatinine that are less than 30% for baseline creatinine values less than 3.0 mg per deciliter do not warrant adjustment in therapy. If greater increases occur, ACE inhibitor therapy should be stopped, and further medical evaluation should occur. Patients with elevated serum creatinine at baseline, up to 3.0 mg per deciliter, may particularly benefit from the vasodilatory effects of ACE inhibitors in the kidney, but require careful drug initiation and close monitoring. PAR's serum creatinine was normal after 4 weeks of lisinopril therapy. She is not experiencing any kidney-related adverse effects from lisinopril. The next question reads, what are the risks of using ACE inhibitors in women of childbearing age? Because ACE inhibitors are teratogenic in the second and third trimester, the use in pregnancy is contraindicated. Moreover, the use in women of childbearing potential is discouraged. If used in this population, patient education should be explicitly clear regarding risks to the fetus, which include potentially fatal hypotension, anuria, renal failure, and developmental deformities. A highly effective form of contraception should be strongly recommended. The next question reads, PAR's lisinopril is increased to 20 mg daily, then to 40 mg daily during a period of 8 weeks. Her current BP is 136 systolic 78 diastolic. It is 134 systolic 76 diastolic when repeated at an office visit today. Her serum potassium and creatinine are unchanged from previous values. However, she reports a persistent dry cough for the past few months. She has no additional signs suggesting upper respiratory infection or left ventricular dysfunction. How should PAR's therapy be modified? A well-known side effect of ACE inhibitors is a non-productive, dry cough, which can occur in up to 15% of patients, with some estimates of cough prevalence being higher. Patients may describe this as a tickling sensation in the back of the throat that commonly occurs late in the evening. This is distinctly different from the cough associated with left ventricular dysfunction, which might be associated with crackles and rales on auscultation, indicating possible pulmonary edema. ACE inhibitor-related cough resolves with discontinuation. Many agents have been used to treat an ACE inhibitor cough with poor results. The best treatment option for a patient with an intolerable ACE inhibitor cough is to switch agents. The next question reads, how is an angiotensin II receptor blocker different from an ACE inhibitor? For PAR, switching to an angiotensin II receptor blocker would likely eliminate the cough. Although her first-choice antihypertensive should be calcium channel blocker or thiazide diuretics, PAR will also require the addition of a second agent, either a calcium channel blocker or thiazide diuretic, because she has not achieved her goal BP of less than 130 systolic 80 diastolic. Angiotensin II receptor blockers are first-line. There are 8 angiotensin II receptor blockers, and many are available as 2-drug fixed-dose combination products, as well as 2 different 3-drug fixed-dose combination products. Let's discuss the pharmacologic differences between an angiotensin-converting enzyme inhibitor and an angiotensin receptor blocker. Unlike ACE inhibitors, angiotensin II receptor blockers specifically bind to angiotensin II receptors in vascular smooth muscle, adrenal glands, and other tissues. Access of angiotensin II to its receptors is blocked, and angiotensin I-mediated vasoconstriction and aldosterone release is prevented, resulting in BP reduction. Angiotensin II receptor blockers do not affect bradykinin, therefore dry cough does not occur. Considerable investigation has focused on describing the pharmacologic differences between the angiotensin II type 1 and type 2 receptors. Stimulation of the type 1 receptor causes vasoconstriction, salt and water retention, and vascular remodeling. Other deleterious effects from type 1 receptor stimulation include myocyte and smooth muscle hypertrophy, fibroblast hyperplasia, cytotoxic effects in the myocardium, altered gene expression, and possible increased concentrations of plasminogen activator inhibitor. Stimulation of the type 2 receptor results in antiproliferative actions, cell differentiation, and tissue repair. Theoretically, an ideal antihypertensive agent would block only type 1 and not type 2 receptors, as is the case with angiotensin II receptor blockers. Therefore, it is possible that an angiotensin II receptor blocker would be superior to an ACE inhibitor in reducing hypertension-associated complications because ACE inhibitors ultimately decrease stimulation of both type 1 and type 2 receptors by decreasing production of angiotensin II. This argument is purely speculative and is not supported by clinical trial data. Ongoing telmisartan alone and in combination with ramipril global endpoint trial, abbreviated as OnTarget, was a prospective, double-blind, randomized controlled trial that directly compared angiotensin II receptor blocker-based therapy, ACE inhibitor-based therapy, and the combination of an ACE inhibitor with angiotensin II receptor blocker. After a median of 56 months, the incidence of cardiovascular events was no different among all three treatment groups. Therefore, angiotensin II receptor blocker therapy is as effective as, but no more superior than, ACE inhibitor therapy in the overall management of hypertension. The next question reads, if PAR experienced angioedema from lisinopril, would treatment with an angiotensin II receptor blocker be appropriate? A history of ACE inhibitor-induced angioedema does not preclude the use of angiotensin II receptor blocker therapy. The cross-reactivity between angioedema with an ACE inhibitor and angiotensin II receptor blocker is not exactly known. The candesartan in heart failure assessment of reduction in mortality and morbidity alternative study prospectively included patients with a history of ACE inhibitor intolerance who were randomly assigned, in a double-blind manner, to placebo or candesartan. Of the 2,028 patients enrolled, 39 had a history of ACE inhibitor angioedema, and only one of these patients experienced repeat angioedema that required discontinuation of the angiotensin II receptor blocker. In the telmisartan randomized assessment study in ACE-intolerant subjects with cardiovascular disease trial, 5,926 patients with a history of ACE inhibitor intolerance were randomly assigned in this double-blind trial to an angiotensin II receptor blocker or placebo for a median duration of 56 months. A total of 75 patients had a history of ACE inhibitor angioedema, and none of those patients who were randomly assigned to the angiotensin II receptor blocker treatment arm experienced repeat angioedema. Therefore, cross-reactivity in angioedema between ACE inhibitors and angiotensin II receptor blockers appears possible, but unlikely and very small. Angiotensin II receptor blockers are an alternative for patients who experience ACE inhibitor angioedema but should be reserved for patients with a compelling indication for an ACE inhibitor. Of note, the ACC/AHA guidelines recommend an angiotensin II receptor blocker in patients who have experienced angioedema from an ACE inhibitor. So there you have it, our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 279.